Bismillah ar-Rahman ar-Rahim. In the name of Allah, the most beneficent, the most merciful. Good evening, everyone. I'm Talha Yunus Khan, currently serving as an assistant manager at the Department of Physiotherapy and Rehabilitation Center at Aga Khan University Hospital. So it is my uh, immense pride and privilege that I stand before you today to present this webinar. I would like to extend my heartfelt great thanks and appreciation to the Sports and Musculoskeletal Society who manages this. The dedication and excellence have paved the way for important discussions like the one we are about to have today. So thank you very much all for joining us today. In this presentation, you will gain valuable insights into the effective management of patellofemoral joints, PFP, and patellar tendinopathy. We will explore comprehensive treatment and rehabilitation strategies designed to alleviate pain, restore functions, and enhance the overall quality of life for those who are affected by these conditions. Our aim is to equip you all with evidence-based approaches and practical techniques that can be seamlessly integrated into our clinical practices. So before that, we need to discuss knee joint. Knee joint is something a very complex joint as well. So we will discuss the marvels of the knee joint as the floating joint illusion. More than it's not just a hinge joint only. So did we ever think that feeling your knees and extend with ease? That's your body engineering uh, marvel at work. Unlike most of our skeleton buddies, the knee joint enjoys a bit of autonomy. So uh, unlike most of the scale, not because it's adrift in the space only, but because it isn't directly bone connected to its neighbors. That this design masterpiece allows for an impressive range of motion from walking and jumping, like dance moves, etc. So knee joint is a very complex, and we have to understand, we have to learn while we are treating patient with the knee problems. Like we have lots of problem knee joint, but their assessment, their biomechanical engineering, their muscle load, weight transfer, lots of things we have to focus on before we should manage or treat patient. We have a differential diagnosis. We have to make a differential plans before assessments and then make a plan accordingly. So we'll discuss detail in later in this presentation. I would like to share some updated facts about the knee joint for the rehabilitation profession. This is quite interesting. So, number one, the prevalence of the knee joint. Knee pain. Knee pain is one of the most common musculoskeletal complaints, affecting over 25% of adults at some point in their lives. Majorly with the people who are taller one, in comparison with the people who have average heights. It is a leading cause of disability, significantly impacting quality of life and mobility. Rising incidence of knee injuries. The incidences of knee injuries, particularly related to overuse and sports, has been steadily increasing. With more people engaging in physical activities, the demand for effective knee injuries preventing and rehabilitation is higher than ever. That means that with more people engaging in physical activity, that doesn't mean that people are engaging in quality good life. They are used to play sports, but their musculatures are not that much sufficient enough to help in these games. That's why the weak, if you put your weak musculatures in the immense activities, that leads to an injury. So economical impact. The economical burden of the knee disorder is substantial, with millions of dollars spent annually uh, on treatment, rehabilitation, lost productivity, and some strategies are crucial to reducing these conditions. Advancements in treatment. Now we are in the 21st century. Recent advancements in physiotherapy, regeneration medicines, and surgical techniques have significantly improved outcomes for knee conditions. So early interventions and tailored rehabilitation programs are key to achieving the best results. Importance of multidisciplinary approach. While dealing with the knee condition, we have to be on with a multidisciplinary team. Managing knee condition often requires a multi approach involving physiotherapists, orthopedic surgeons, sports medicine specialists, and other healthcare professionals. Collaborative care ensures comprehensive treatment plans and better patient's outcome. Because if we are dealing alone as a patient for a patient, we don't know the nutrition supplies to the patient. We don't know the medical supplies to the patient. That's why multidisciplinary approach is very important. Evidence-based practices reveals that. In majority condition, we are giving 100% to the patient, but the symptoms of the patient's not improving. So at some point, we got to know that their nutrition supplies are compromised, or other components are compromised. So that's why multidisciplinary approach is very important while dealing with the patients. So with these facts, we came to know as a physiotherapist, we stand at the forefront of a rapidly evolving healthcare landscape. And we are serving, our servings are increasingly recognized as essential. So guys, we are truly sitting on a gold mine nowadays. So our expertise and our knowledge by doctors and fellow healthcare professionals who understand the critical role we play in improving patient outcomes. In today's world, where living standards are declining, as we all know, sleep quality is poor, and healthy habits are often neglected, the need for physiotherapy has never been more urgent before. The demand placed on our profession are growing day by day, and it's imperative that we remain agile, proactive, and ready to meet these challenges heads on, both now and in near future. Our commitment to enhancing mobility, alleviating pain, and promoting overall wellness position as key contributor to the well-being of the communities we serve. So that's some good news for us, because as we all know, physiotherapy was neglected field before, but nowadays, as we are working in the 21st century, evidence-based practices, and the conclusion, somewhat where many consultant physicians, nutritionists came to know that some part of rehabilitation or exercises is more crucial than others. So now people are recognizing us, focusing us. So that's a good sign for us. So guys, we are in gold mine. Back up yourself and ready for that. So moving on the last slide, question and answers. We are inviting you to ask questions and share insights as we continue to advance our collective understanding and treatment of these common yet challenging knee conditions. So my summary conclusion is, uh, while dealing with knee injuries, we may just not focus on the point of care and or the area of pain. Biomechanically, we have to our assessment very focused, and we have put maximum time to the assessment. Majority patients come to you and think they will come and assist and treat on the same day, but that's our expertise to teach them accordingly that the assessment are the main part. And during the assessment, all parameters, biomechanical loading, weight transference of the patient, muscle abnormalities, muscles imbalances are very crucial. Patient history, very crucial. Patient activities and daily living, very crucial. Patients daily appetite, daily sleeping habits. So detailed assessment is a key factor to understand and to make a plan for the patient that will help the patients to improve their condition and their life later on, and to minimize reoccurrence in these conditions. To training and teaching, very important. So thank you very much, guys. Thank you for bearing me for an hour. So it's now time for question and answers. If you have any answer, please let me know. So we'll discuss accordingly. Thank you. So what are the key indicators that a patient is ready to return to sports or high impact activities after recovering from PFPS? So my answer is, while treating the patients, we have three phases of treatment. One phase is initial phase where we are focusing on pain management only. We are focusing on to start rehabilitation process and start process while healing will start. And in that particular phase, maybe up to 2 weeks, we are focusing on this. We start with little asymmetric contraction, with little joint mobilization to rule out stiffness, and then later within the grade 2 activities, we start the closed kinetic chain exercises. Start with the open one, OKT, open kinetic chain, then later the closed kinetic chain exercises. Then we make patient towards the normal daily living activities without in sports, and we will make patient start with the on the drift board, on the balancing boards. We check the patient pain at different levels and different activities. We will start doing some activities, intense activities with the minimal pressure. So with time, we'll teach patients accordingly. We will check the response of the patient. We cannot have appropriate and accurate timings. So we will start these kind of activities maybe after 2 to 3 months, and depend on the condition of the patient. If the patient is have a injury level, depend on the injury level again. So depend on the injury level, depend on the responses, depend on our assessment, depend on the patient adherence to the activities is very crucial, very important. Hope I get your answer. You got my answer.
Uh,
Why electropod?
Mr.
Yes.
Kalasad, I'm Asif Khan Babar. Can I add something in it?
Yeah, sure, please.
So your answer is very good, but because I'm a lot of patient looking every day, which is actually related to sports injuries, I want to
Then
add actually because the question is very valid, and a few things I want to add. Actually, she is asking about the patellofemoral pain and patellar tendinopathy. So the first phase, yes, reduction of the pain, and the second phase, we can improve the strength by heavy, slow resistance exercises. It should not be in a compressive position for the both. And number third, we must check any movement dysfunction around the hip joint, and that could be the internal rotation of the femur or adduction of the femur. And because poor lack of activation of the glutes medius and the maximus muscle can basically change the uh, 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 compressive
orientation.
forces on the patellofemoral joint and the patellar tendon. And number third is very important, which is actually the basically speed of the muscle contraction, which can be built by some biometric exercises. And number fourth is actually the sports specific exercises, which could be add in drill specific to requirement of the sports. So these are the main thing which should be considered in our treatment as well. Thank you so much.
I have another question. Effectiveness of ultrasound therapy for patellar tendinopathy. Yes, some researches evident that ultrasound can be useful in early stage of treatment, like in initial stage where we require healing, or in individuals with older age where degeneration of patellar tendon is there. So there are some evidences shared, evidence-based results shared that use of ultrasound is important in these conditions that will help to eliminate stuff from there, plus and promote healing in such conditions as well. But majority researches reveals that in an initial stage, ultrasound will helps. Majority of the research is for in patellar tendinopathy reveals very good results with shockwave therapy. Okay. Amir, maybe you will add something here on steroid injections in knee joints. Maybe you're expert
Yeah,
on this.
yeah. I think I seen two patients recently. One was the quadriceps tendinopathy, and he was a deadlifter. So bilateral quadriceps tendinopathy, and as you can see that he was a young lad, maybe 21-year old, and then he developed the bilateral quadriceps tendinopathy because of the powerlifting. And then there is another guy who has a little bit of hyperextension of the knee, and he developed the patellar tendinopathy and enthesiopathy, and there was active enthesiitis as well. So in both cases, what we did is that obviously the amount of hypervascularity or enthesiitis was so high that we thought that it's not going to get better without any intervention, regardless how much intervention we will do or how much rehab we will do. So what we have decided under the ultrasound, we put a little bit of cortisone around the tendon, not in the tendon, just around the tendon, like a bathing or showering the tendon with the cortisone to help calm down the enthesiitis or the activity or the inflammation. So during that period, 4 weeks after the injection, they're not going to do any activity, any high impact activity after that. So that was just a one-off steroid injection we have done for that. And after 4 to 6 weeks, we done the PRP for them. So really, a platelet poor PRP would be very, very beneficial, not just to help calm down the further inflammation in the tendon, but also there is a research that it would repair the tendon as well. Yes, and that after the PRP, your rehab starts. So all the taping, possibly low impact exercises like aerobic exercises, then moving on further to more advanced exercises. But until unless you do some kind of intervention, if there is an active enthesitis going on, it's not going to get better. So there is a role of a steroid, but you need to be using it very, very carefully, cautiously, and then it is important to for the patient to understand it that if they do any activity within 4 weeks of steroid induction, there is a high risk that the tendon will tear. Is there any other question related to the injection at this point in time? I'm happy to answer.
Thank you very much. Your detailed response. Absolutely, that's very helpful for us and for me as well, because that's very interesting for me to learn about you. Thank you very much. Thank you very much again, and very good, very big. Bye bye. Allah Hafiz. Have a nice day. Have a nice weekend too. Allah Hafiz.